So one of the other enduring conflicts that we've had is in spinal cord injury care, which is such a substantial problem, the role of steroids. And we've flipped and flopped back and forth, and we thought another highlight of this packed day, I thank our lecturers, thank all of the audience members here and online, is the steroid debate in spinal cord injuries. So the two superstars are going to battle it out here, Michael Fehlings and Jim Harrop, and we'll lead off with Dr. Fehlings. Michael, thanks for joining us. I know you had a very busy travel schedule.
Yeah, thanks, Jens, and congratulations again for putting on the course. You just literally got off the plane from South Africa, where I was at the World Federation of Neurosurgeons meeting. So it's a pleasure to participate in this course. So the title I've been given is that steroids work in spinal cord injury, but I might modify the title a little bit to suggest that perhaps this is a case where I think we kind of need a nuanced approach to the use of steroids and to personalize the use of this. So I would suggest that this has sort of been like a pendulum which has gone back and forth. And I think what we need now is kind of a middle ground. So I don't have any disclosures that will impact on this talk. I have spun off a regenerative medicine biotechnology company, but that's with engineered neural stem cells. And I just want to thank Jens and John. It looks like a fantastic course. So I'm debating Jim Harrop, which has been ironic because we published 134 articles together, including a number of articles on the use of corticosteroids. And Jim is an academic and a clinical superstar and a great friend. And the other irony here, of course, is that Jim actually is an advocate for what I might refer to as a kind of sensible application of neuroprotective agents, including corticosteroids, in spinal cord injury. And so, by way of evidence for this is the clinical practice guideline published in the Global Spine Journal in 2017. I think this is really kind of the best summary of the evidence, and you'll see that I was the first author on this, and Jim Harrop is actually the senior author on this article. And this is one of the key conclusions from the article. We suggested a 24-hour infusion of high-dose methylprednisolone and semisuccinate be offered to adult patients within 8 hours of acute spinal cord injury as a treatment option. I think this is kind of the bottom line, that this is kind of a treatment option. The quality of the evidence was actually felt to be moderate. And this is a more recent article that Jim participated on with our group, and this was talking about really a concerning decline in the use of methylprednisolone, and that in fact one of the conclusions of the article was that knowledge translation needed to occur to inform clinicians on the appropriate use of methylprednisolone. And so it's not that methylprednisolone should always be used, but also that it's not appropriate to indicate that it's should never be used. It's an option. So this is sort of like the steroid wars, and so this here Jim and I are kind of duking it out, trying to protect our patient here, characterized by Princess Leia. And I guess this is kind of Jens and John here providing the wisdom. So there's a strong biological rationale for the use of corticosteroids, and the main focus of this is to try to attenuate the secondary injury processes that occur after the primary mechanical injuries. And they have a strong anti-inflammatory property, and this was kind of summarized in an article that our group put out in this 2017 issue in Nature. So steroids improve vascular perfusion, they prevent calcium influx, they modulate inflammation, and they attenuate lipid peroxidation and other secondary injury factors. And the science behind this was developed by one of the true pioneers in the area of neuropharmacology and spinal cord injury. And this is Ed Hall, who, after leaving Upjohn, became kind of the endowed chair at the University of Kentucky. So I think, I hear some people talk about, that the evidence is really poor, or there is no evidence around corticosteroids. And I wanted to kind of really strongly come on the opposite side of that, because the evidence here is actually quite strong, and the science is quite strong. Now, the challenge, of course, is to try to translate this into clinical practice. So there's been a long history of trials with corticosteroids, and ASCA's one trial actually did not have a placebo control because corticosteroids were felt to be a standard of care. And they used a low dose versus what they felt to be a high dose, and there was no difference in neurological recovery. And based on this, Dr. Hall and Brockler went back to the lab and actually looked at a lot of the mechanistic work with corticosteroids and revised the dosing. And then this led to the NASCA's 2 trial, which was actually a 3-arm randomized trial of methylprednisolone, naloxone, opiate antagonist, and placebo, 487 patients. And in a subgroup analysis that was pre-planned, but it was a subgroup analysis, the motor and sensory recovery did improve in patients given within 8 hours, although the overall effects, including patients beyond 8 hours, did not meet significance. And then this was followed by the NASCA's 3 trial. And essentially what was suggested was that earlier use of corticosteroids within 3 hours was more effective, and that if a treatment was delayed after 8 hours, that potentially a 48-hour infusion of steroids could be considered as an option. The challenge with this is that the 48-hour infusion of corticosteroids is the option that starts being associated with greater side effects. In 2012, there was a Cochrane meta-analysis, which essentially kind of validated that there was a positive effect of corticosteroids in spinal cord injury. The big problem with this was that the author, unfortunately, was Michael Bracken. And this was a pretty significant conflict of interest because Bracken, of course, was the first author on the landmark corticosteroid trial. So I think this was kind of unfortunate. So, based on all of this, I think it is fair to say that, the pendulum at one point, it swung too far in favor of steroids. And at one point it was kind of felt that this was, the standard of care and all patients would receive corticosteroids. But, as I've kind of presented, there is positive evidence, but it's not like it's overwhelming. Then this was followed by a strong push against the use of corticosteroids. And the chief person here is actually one of my former fellows, a Toronto graduate, John Hurlbert. And, he kind of cited some inconsistencies in the literature, but in particular pointed out that, the key evidence in favor of corticosteroids was a subgroup analysis. So in 2002, the CNS-AANS guidelines came out, and these essentially indicated that treatment with methylprednisolone was recommended as an option. Then they pointed out that there were, that one needed to kind of look at the literature carefully to kind of make your own decisions. And I actually think that this 2002 guideline was actually quite appropriate. The problem came out with the 2012 guidelines, which came out with a level 1 recommendation against the use of corticosteroids in the absence of any level 1 evidence. There were no randomized trials indicating that corticosteroids were ineffective. And this was really just, I think, kind of an emotional response to this shift in the pendulum. And I think this was the issue, these 2012 guidelines. And because of these guidelines, there's actually been quite a significant reduction in the use of corticosteroids. So in 2009, from our North American Clinical Trials Network data, about 3/4 of patients with spinal cord injuries receive corticosteroids, and this use is dramatically reduced. And this is probably inappropriately low. So I think the pendulum has swung too far against the use of corticosteroids. And so this potentially also can have a negative impact on translational research, because I think that it has raised such a high bar that this has actually been a turnoff for a lot of biotechnology companies to get into the spinal cord injury space, because the view is that, well, even if a positive effect is seen, clinicians are going to be reluctant to accept this. And I think that there needs to be a greater level of maturity in terms of how clinicians kind of review these results. So I think the bottom line is that we kind of need a middle ground. And so kind of the data do support the use of corticosteroids, but there are potential complications that we're aware of, particularly with the 48-hour infusion of corticosteroids, and there are higher rates of infections, and there's a somewhat higher risk of thromboembolic complications. But these side effects are generally kind of manageable. So while it's certainly true that the evidence does not support kind of the standard of care routine administration of methylprednisolone, there is evidence to support its use as an option. And this kind of spurred a re-review of this literature, and this came out in the 2017 guidelines that I referenced previously. And this is kind of one of the key tables. This is a forest plot of the clinical trials data, and then this is the mean and the 95% confidence interval. And this was done by an independent group of statisticians led by Joe DeTore of Spectrum Research. And this showed around a 4-point improvement in the motor scores. So when you consider this, let's say you have a thoracic Asia A patient, a 4-point motor improvement isn't really necessarily going to have a big impact on the patient. But if you have a cervical patient, particularly one who's incomplete, this could be quite meaningful, because this could result in significant restoration of hand and upper extremity function. And so I think one of the messages here to consider is the use of corticosteroids in patients that are not frail medically, so that can tolerate immunosuppression, so younger patients, and then patients with cervical injuries and incomplete injuries. And so then this is a clinical practice guideline that emerged. And so for patients presenting within 8 hours of a spinal cord injury, it was suggested that the 24-hour infusion be a reasonable treatment option. And we actually recommended against the 48-hour infusion. And we also indicated that high-dose corticosteroids were not recommended if patients presented after 8 hours. So in a sense, what we've done here is we've actually kind of synthesized the 2002 and the 2012 AANS-CNS guidelines to try to make sense of what appears to be kind of a contradiction in the literature. Now, although I've been kind of labeled as a big proponent of corticosteroids, the reality is that I'm a proponent of trying to look at therapies that will help patients, and corticosteroids are definitely not perfect. And I worked with Fred Geisler on this paper that came out, and essentially this was a synthesis of the Cygen and the methylprednisolone data, but with a significant caveat that this was a very restrictive analysis, and that the positive effects in the cervical and the conus injury groups were significantly diluted. And so I think it would be worthwhile to read this paper. But I think kind of the bottom line is the original statistical analysis of the NASCAS trials were actually confirmed in this, in this analysis. So there actually has been an independent verification of Bracken's results. So the challenge with spinal cord injury is very heterogeneous, and so like here is a graph that looks like a snowstorm in a Toronto January. I've plotted out the upper extremity motor scores over time in patients with incomplete cervical injuries. This is a subset of our NACTIN data in over 800 patients, and so we have to consider the different heterogeneities of these types of patients. And again, I think cervical patients, and particularly patients with incomplete injury, are good candidates to consider the use of corticosteroids. And so I think one needs to really kind of personalize, the management for the use of corticosteroids in spinal cord injury. So spinal cord injury is a devastating condition. There is currently no, reparative or regenerative therapies, surgical decompression, intensive care, hemodynamic management, rehabilitation to improve the outcomes. But small neurological gains can result in a significant gain of function, particularly in a quadriplegic individual. And given the lack of alternatives to corticosteroids, I think that we need to kind of reflect on the data here and to look at it realistically, that this is a practice option. And I would actually advocate for an acceptance of 2017 guidelines, which have been independently reviewed by the Institute of Medicine and found to be of high quality. And I think the decision to give steroids should be personalized to each patient, and really these treatment decisions should be left in the hands of the physician. Importantly, patients, when they are actually surveyed, as in this paper from Greg Harlock's group, actually very strongly favored the use of methylprednisolone when they are presented with the data that I've just shown you, including looking at the slight increase in risk of infectious and thromboembolic complications. So this is also, I think, an important consideration. So the bottom line is that the decision to use methylprednisolone should be left to the discretion of the physician and the patient involved, balancing the potential for benefit and the complications given the characteristics of the presenting patient. And the factors that do support the use of methylprednisolone are cervical and conus injuries in patients that are less sensitive to potential complications, younger patients with fewer comorbidities. And so just by way of additional reading, I would refer to you to this textbook that we've put out on traumatic spinal cord injury. And just for your interest, we have a textbook that's just come out on degenerative cervical myelopathy as well. On that note, I'll close, and I'll look forward to Jim Harrop's comments, and then maybe in the discussion we can try to come up, with some kind of a synthesis with some take-home points for the clinicians to take away.
Outstanding, Michael. Thank you. Very balanced and nuanced. Let's see how nuanced the response from Philadelphia will be. Jim has walked up to the lectern with a smirk on his face.
Oh, no, I'm up here. Michael, I just want to say right now, I was given this topic by Jens, so anything I say or any hatred towards me should be directed at Jens, because I'm going after your jugular. Jens, I think I'm not an Apple guy either, so I just pretty much deleted my talk. All right, so let's just go back to Michael's talk.
Microphone.
Michael, so let's just go back to Michael's talk. So there's a couple, and the younger people out in the audience, very good tactic. So when you debate someone, you have to say, how am I going to approach this? Am I going to go with the facts and the data? That's what I've decided to do. When you don't have that on your side, you have to go otherwise. So Michael used the distraction method. I'm going to throw a bunch of slides with messy things. I'm going to do an infomercial and show you my book that you should buy. And the other thing he did is the emotional argument. I went to the patients and they're quadriplegic. You need to help them people. So it's a good tactic. If you ever, it's down here, steroid one. It's a good attitude. If you're not going to win, you might as well just try to deflect and everything. So steroids don't work. And who's one of your residents or whatever?
Dr. Patel
Right.
would like
This
to
is the world's
answer this.
literature on steroids. So just to prove I read it, I probed them out. You guys should save this. This would be a great journal club for you. Jens? All right, Michael, you ready? This could be an earlier talk, but whatever. So I give Michael a lot of credit, and he is absolutely one of the world leaders, although it should be pointed out that at the beginning of the talk, I was the senior author. Did we all point that out? So I guess I am more knowledgeable than my mentee who wrote the article. So with that said, I stole this article from Michael, and I think he's right. Lipid peroxidase is how it works. The question is the animal data is there, but there's a billion articles out there. Oh, you guys are killing me. This is not my talk. Whatever. I'll go with it. Anyways, this is my earlier.
Do you want me to look for this?
Don't worry about it. I'll just go with it. When the Germans burned Pearl Harbor. All right. So with the injury, you get an attack, and you have to believe there's a secondary mechanism. You got to remember when this came out, there wasn't even really a belief about a secondary spinal cord injury. And one of the problems with time and why people's attitudes about spinal cord injuries, Bracken's articles back a long time ago were the best. The problem is our understanding of peer-reviewed literature and evidence-based medicine has drastically changed. And as you go through an article, I read those articles 30 years ago and thought they were great. I read them again, and I'm going to point out some of the weaknesses. So this is the world literature. Class 1, okay? There it is. Those are the 5 papers. And we're going to go through those, and I'm going to essentially trash every one of them. Class 2, 3 papers. Class 3, and this is most of the literature, 10 papers. So going back, and Dr. Hall, totally agree with Michael. It's actually funny. I did not see Michael's talk or anything, but we hit the same points. We're just going to be arguing different sections of it. Dr. Hall did all this work on it, a true genius person. NASCUS 1 came out, and what did it show? Anyone? Didn't work, okay? It did show that there was, and you're going to see this consistent theme, there was a 4 times higher risk of infection with steroids. So not a good thing. So since it's Christmas time, I made this very easy for everyone. Red means evidence, their paper's conclusions were, doesn't work. Green is their paper's conclusion was that it was good. Pretty easy. Even John France, you got that?
I'm trying to follow.
The problem is when you write a paper, you get to write your conclusion. Now, let's go back and look at the evidence and go to their conclusion and see if it was valid. So we're going to go through and we're going to pull out some of these papers. Tokarski paper, very interesting paper. We'll go through it. That's first. This is a paper wrote in Poland. Okay, now this you got to remember. This is the evidence that steroids are good. 620 patients. They broke them down, basically 300 and 300. But here's the funny thing. They gave steroids, but no one defined what the steroids were. And it was up to the doctor to decide what steroids were. And then the second thing that came up, they came up with a neurologic exam. No one's ever used it before, never validated. So this was their conclusion. Hey, use steroids. Patients percenting get better. The problem is when you go read the paper, which I got to tell you, even I don't think I wrote a paper this bad. It's like written on toilet paper and it's like 2 pages long. When you go through and read it, the non-steroid patients all died. And so your conclusions are, okay, groups aren't controlled. You can't really make much out of this paper. So I'm going to give that one a neutral at best. So we put it as orange. It definitely doesn't support the use of steroids. So let's go to the Atani. Atani was after steroids came out, Japanese paper, written in Japanese, later translated. Not a bad paper. But what they did is prospective randomized, so we give them credit for that. Patients fell out of the control groups. So in an ideal study, you make your 2 groups, they come down, and then you and someone gave the fruit or analogy before, you're measuring apples against apples. The problem is most of the control group fell out, and they left the study for whatever reasons. And so it's not really apples versus apples. And what was their conclusion, John? Primary analysis?
Better. No difference.
No difference whatsoever. But again, Dr. Otani got to write the paper. So what was Dr. Otani's conclusion?
Works.
No, he said they did great. And what he said was, the primary analysis didn't work. So what are we going to do? Let's do a post-hoc analysis. Okay? And this is where you're going to get this theme later with Dr. Bracken's paper, his NASCUS 2. And what he did is, the patients actually got a statistical improvement with pinprick, light touch, but not with motor. But the important part is he actually went back and looked through the data. And us being statisticians, what do we know? Anyone know why they came up with a p-value of 0.05?
Oh,
Huh?
arbitrary 500.
I was a math major, so I had to take stats course. And so someone asked, hey, why do you get 0.05? Well, if you're old enough like Jens and I, when you did stats, you have to go to the back of your book to find your p-values, to correlate them. And how they do the tables? By 0.05s. And so that's why it was easy for people to use that for a stats. We as scientists use it because it's easy, but now we have computers. Your p-value can be anything, but we always go to 0.05. And what's 0.05 mean?
500.
What?
Random chances, 5%.
5%,
Yeah.
which is 1 out of 20.
Yeah.
Remember that, because we're going to go to NASCUS 3 when we come to that one. So here we go. Next study, we're going to go to Dr. Bracken's paper. And by the way, I'm throwing stones at this paper. This was the best thing at its time. You got to remember, this is late 1980s, early 1990s. This was one of the best studies out there, ingenious, but you're looking at it now to the 2020 metrics. And in order to be a class 1 paper now, you have to have all these things in it. It has to be well designed, well executed, the data's got to be there, control groups, everything. Here it is. And again, it was a 3-arm study. A lot of people don't remember that. Michael said that. Here's the conclusions of the study. I did my study. I looked at it. And what did they show? Motor stores. And we'll go back to the, hey, anyone do a study where you only look at one side? Kind of bizarre, but whatever. How about pinprick? Any difference? I'm sorry, I didn't go. That's your motor score. Same. How about, How about sensation? Ooh, look at that. Tiny little difference. Maybe that's good. Not statistically significant. Touch? We're talking 1 point there. You guys ever do an ASIA score on a patient? If you haven't, 1 point is really hard to tell a difference. Go through, statistically significant? Nope. So primary data comes out. What's the conclusion, John? No difference. So what do you do when you got all this time and money?
Post-hoc.
You do a post-hoc analysis. Now, there's a lot of criticism of this, and I'm not going to say anything bad about anyone, but there was a belief that it was done on the median time. What was the median time? It was 8.5 hours. So why was it 8 versus 9? I don't know. Never was brought up. One of the criticisms I do think is very fair, and there's a lot of people that have written a lot about this. Dr. Bracken did not put a lot of data into his papers. And so there wasn't a lot of supplemental information. There wasn't a lot of statistical things that probably would have been provided today. But when you go back and read this stuff, you're going to find out a lot of this stuff's not there. So when you do your post hoc analysis, what do you got? It's a great opportunity. Now you only got to do, you might as well measure how many things? 20. Because your odds are you're going to find one thing out of 20 of them that's wrong. And so what did he do? He broke it down to less than 8 hours and greater than 12 hours. And what's the problem with doing a post-hoc analysis? Michael's Fehlings, other big area of advocacy, early surgery. So why don't we weed out the people that get early surgery and say, hey, the benefit of early surgery is due to steroids, when it's really the early surgery that might have gotten them better. So he breaks it down to that, and he goes through it, and this is the unbelievably great data. Ready? Change your mind, everyone. Oh, at 6 months, you get statistically significant data. The problem is what? At a year, everything goes back. So what they decide to do? I'm going to report the 6-month outcomes instead of the year data, because they lose all significance at a year. Pinprick, right side, left side. Again, actually going back, only motor stayed up at a year. All right. So a lot of problems with the internal consistency. There's a trend of improvement. Oh, I don't have my best slide here. So what I don't have here is Bracken wrote another paper. This was an earlier version of my talk. He wrote another paper. He published it in a journal of neurosurgery, and he was trying to explain his inconsistencies. And when you pull out the graph on the less than 8 hours versus the greater than 8 hour group, it's not the benefit of steroids makes them better. The statistical difference actually comes in the control groups. So the people in the control group in the less than 8 hour group did significantly worse without steroids. And it wasn't that there was a benefit. And so when you look at the graphs, which I don't have here, one's here and one's here. And you're like, well, if they're control groups, shouldn't they be equal? And so the whole benefits might not be, it goes back to the what? 1 in 20% chance. So I'll get that. So again, when you look at this, steroids may have a benefit in a tiny group, and I didn't even concentrate on this. There is a potential bad with everything. And when you look at steroids, there is definitely an adverse effect on some people in some groups. And I'm not going to go through them all, but it's all the data shows that, yes, you're risking your patients to a potential bad side. So when you go through all these things we talked about, great idea, well-intentioned, but the data is not there. So we keep on going through. That one's not good. Now we go to this. This is the 48-hour data. And again, Michael, not to say you're biased, but yes, you are in that group. these are the different groups. And really what it comes down to is this. The difference is, here it is right here. The difference is between 17, no, sorry, killing me. The difference is 11 versus 17. Now that's important. Remember that for a second. The bigger issue why no one wants to use a 48-hour one is what? Again, the infection risks and sepsis are much worse. But here's the interesting thing. If you go into this group, and this is a spinal cord injury study, right, John? Was it a spinal cord injury study? So if I told you, John, what percent of normal patients do you think should be in a spinal cord injury study?
None.
0? So when I tell you 25% were normal? Normal. Does that bother you?
It's hard to get better.
It's hard to get better. And so when you look at that, you go, okay, maybe this great study might not be as not great as I thought. So then you go back, and again, 11 points versus 17 points. You're like, okay, maybe that 5 points is a difference. The problem is when you take out, and this is a guy, there's one of the papers I get to is a guy named Coleman. He's actually the statistician that worked with Fred Geisler in the Seisen study. One of the smartest people I've ever met. He went back and tried to figure out, well, what would the stats be if I knocked out normal people? And what did he find out? The difference would probably be 18 versus 20. A one point difference in your motor thing. And so you'd argue maybe the steroids didn't work. There are people, and I'm not going to delve into this. John Hurlbert's done a lot of different battles and different things. If you know what a Gaussian distribution is and you look at the stats, none of the stats Bracken did were based on, he used all Gaussian distributions, but what do we know about spinal cord injury populations? They're usually non-Gaussian, right? Because you got people that don't get better, you got people that get better. So there's a big complex with that. Second thing is Hurlbert's been an advocate and basically says nothing is all good. You have to look at the negative sides. Then we get to the people that are a lot brighter than me. And don't forget, a very small minority of people were were different at the 2002 versus the 2013 guidelines. So this group came up, and I think Michael's probably about right, is that there's not a lot of evidence in that maybe it could be considered an option. The 2013, when you come through it, is they basically say what? They say it should not be used. And so the AO guidelines, we talked about it, basically was based on a weak amount of data. And basically what it says is weak recommendation that it should be offered, Michael. Doesn't necessarily say it's useful. And this is what I stole from Brian Kwan's data. And this is kind of funny because I, again, didn't know Michael's talk was going to be about a pendulum. I do think the world's gone from one extreme to the other extreme. I don't think it's unreasonable to offer people anything, particularly spinal cord injuries, because one of the most moving things I will tell you in my life was to sit in that AO room with some people that were quadriplegic or tetraplegic and them say, we were arguing back and forth whether 5 points were meaningful. And this physician in the back raises her hand, comes up and says, you guys are assholes. And I'm going to paraphrase, obviously. And she said, I would do a lot to get 5 points. It means that much to me. And you're like, okay. So you have to remember what your values to your patients are. And sometimes as physicians, we don't do as good a job as we can. So to me, I think that's very much influenced me. So I think, yeah, it's a good idea to offer it to your patients, but you got to remember, with all good things comes potential bad. Now, lastly, we're going to come up to, because there's an old story about, you know, that show, Who's Smarter Than a Kindergartner or whatever the thing, they have all these people in a room. The mean is always smarter than the individual, right? You ever heard that, John? Maybe in a family reunion with you, it could be different, but I'm just saying the mean is always smarter than the individual. So here's a poll of neurosurgeons who say basically, do you think steroids are good? And so you can ask Mike Fehlings, who's that guy there, or you could listen to the mean, which is everyone else, that says they're probably not helpful. And last thing, and Michael talked about this. This is a study I did, or actually we did, and we looked at the Nacton group and we said, well, where have we gone with steroids? And it's very interesting. As you follow it out, the guidelines actually came out in 2013 against the steroids, but the group sort of started in 2010, sort of on their own before the guidelines came out not to use it, started to say, well, maybe I shouldn't use it. And so Michael's presumption that in 2013, which is here, ended the use of steroids probably isn't totally correct. And again, Michael's one of the lead authors. And there he's the senior author on the paper that said, no, none of us use steroids. So with that, I say thank you. And the last thing I just want to point out, which I actually is not in this slide, is if you look at a timeline of changes in conversion rates, and I had a slide in here which is very interesting. If you go through and look at our conversion rates from the 1990s to 2000s, the conversion rate was about 3 to 5%. Conversion rates now are about 25 to 30%. And if you follow it out, when the guidelines for spinal cord injury came out, they said to use hypertensive therapy in patients. That is when the conversion rates started to get better with spinal cord injuries. And it was actually before Staskus came out. So it's really interesting. To me, probably the greatest thing we've done in spinal cord injury to improve outcomes is not steroids, probably not early surgery, but probably is hyperperfusion of the spinal cord. And I think, as Michael said, we have to do many things. We have some questions, and Michael, you can rep my Christmas card.
I have a question. You can answer.
Can we get Michael
Jim.
back on the screen?
Great job, Jim.
Either you or Michael can answer this or both. Has anyone ever looked at the subgroup of Asia A's with steroid? Because for them, one root level is very important.
Yep.
Like what you said, Michael said. Has anyone ever looked at specifically Asia A's? Because, if you've got a 4-point improvement in one muscle group, that could change their life dramatically. Has everybody looked at adjacent level nerve roots in Asia A's to see if it improves that recovery?
So what John's talking about is, and I'll paraphrase, there's something called root escape. If you go back to Frankel's work, Frankel showed that most people get one level back. And it's probably because it's not a spinal cord injury, it's a lower motor neuron injury. And so those patients tend to get that back. Your question of does steroids increase that to more?
Yeah.
And that's why, and Michael's been an advocate of this, is if you look at most spinal cord injury research now, we're sort of pulling out the thoracic patients because all they do is dilute your effect. It's really hard to get, 12 inches or 2 feet of neuron regeneration. And can you see an effect easier or earlier in 1 or 2 centimeters of the cervical cord versus 2 feet? So most people have sort of started pulling out the thoracic spinal cord injuries in their studies for 2 reasons. One is the mechanism of injury is usually a lot worse, and 2 is neuroregeneration, I believe, is a lot harder.
Yeah,
Mike?
so I'll maybe kind of respond to that as well. So I think that we've learned a lot in terms of how to do clinical trials, and I think we've learned a lot from kind of Bracken's trials, and some of the things that we've learned are that the patients with cervical injuries are more responsive to neuroprotective treatments because we're trying to get 1 or 2 levels back in the spinal cord. And so in the thoracic injury, that's really not going to have a significant functional impact, but in a cervical injury that will. And so, the evidence that corticosteroids have a greater beneficial effect in cervical injuries is there, which is why I'm suggesting that that's a subgroup of patients that you might want to consider. Jim Harrop made reference to the Staskus study on early surgery, and one of the points that just to reemphasize is that in the Staskus study, we actually had to control for the use of corticosteroids because there was a positive interaction effect between early surgery and the use of corticosteroids. And in Bracken's studies, early surgery was not really the standard of care and it wasn't really controlled for. And so, it's kind of ridiculous to think that if you've got a compressed spinal cord, that the use of neuroprotective agents is going to have any kind of a beneficial effect. So, I think that, Jim in his last few slides could have referred also to the pendulum, which I kind of made reference to. And I think at the end of the day, the data are what they are. I would say that the 2017 systematic review and guidelines are probably the best synopsis of the evidence. And the evidence is that really that it's an option. And the recommendation was kind of at a weaker level because it was subset analyses. And so I would say that in younger patients that are not medically frail who have a cervical injury, it's a reasonable option, to use that, but it's certainly not a standard of care.
Would it be worth, Michael, looking back at the data and just taking the Asia A's and only looking at the root motor scores at level, one level above, two levels above, and compare just those two data? Because I think that's where maybe the meaningful data would come. I mean, it may be worth just that subgroup of patients.
Yeah, so we've actually combined the data with Cygen, and I made reference to one of the articles that we've published where we used kind of a very stringent analysis where we actually excluded patients with kind of the cervical and the conus injuries. And I think that what will be interesting is to do an analysis on the cervical and the conus injury patients, as you suggested. And so that's currently underway right now. But my sense is that these are the subsets of patients where we may see kind of a beneficial effect. But one of the challenges kind of with dealing with the methylprednisolone data is, Jim Harrop has indicated, is that, they unfortunately included a lot of patients that were what we call Asia E. So they had a cord injury, but by the time they saw the physicians, they had improved almost a normal level. So that dilutes out the effects. And then the other challenge in that era was that, surgery wasn't really controlled for. But in any event, the subset analyses are currently being done.
Could I just pull up my slide 1 second? I just want to show the slide I was talking about. And the funny thing is, since I already won debate, I can say this. Michael and I actually have a pretty similar philosophy. I do think you should offer it. I mean, the diabetic 80-year-old person with a central cord injury not getting it, the 17-year-old healthy kid with the Asia A, in my world, talk to them about steroids, use it. I think the risk is probably beneficial to the adverse and get them to early surgery. And I think it's not a one world pony anymore. Early surgery, steroids, keep them hyperperfused. There's a question in lumbar drains. Should you hypothermia them? I think there's a lot of things out there that we're still working on.
So, you want to show a slide. So,
can you show my slides?
So, Michael, thank you again for coming together. It's extraordinary circumstances, and
can you show my slides one more time? Sorry.
So Ben is putting up a slide that Jim wanted to get back to. My question pertains to the risk factor. So in modern day trauma care, this increased infection risk, this risk of pulmonary deterioration, GI bleeds, isn't that an anachronism? I mean, these are historic things that are still bantered around. And with modern glucose control, metabolic control, proper antisepsis, proper mobilization, I've just not seen those. And Harborview, as you know, is one of the NASCA's 2 sites. So both of you, are these overstated complication risks?
I think that they are, to be honest with you. So, we did recommend against the 48-hour infusion of corticosteroids because that was the subgroup where, the complications were a bit higher. My own experience with the 24-hour infusion is that the patients tolerate it really well. And I think also kind of with modern medical management, we're just not seeing these, these issues, kind of arising. So, and I think if you're selecting patients that are, say, not medically frail, I think, age is a relative factor. I think probably medical frailty is the issue. So if you are excluding patients who are medically frail, and if you're, say, excluding patients who have a very severe thoracic cord injury, focusing on cervical patients, incomplete patients, the complication profile with corticosteroids are quite favorable, particularly with modern medical management. So I don't think that needs to be a huge concern. So I actually agree with your perspective on that, Jens.
Yeah, I totally. There's 2 things that don't happen as much. we published our infection rate with spinal cord injuries. It was 12 to 16% back in the days, which we don't see as much. I mean, ours is down to about 1% now. Number two thing, and we don't see GI bleeds. I remember them dying routinely with a spinal cord injury from GI bleeds. I mean, we never see them. The GI guys used to hate us because they'd have to go put the balloon pumps in patients, but almost never happens. Really quickly, these are the two slides I want to show. These are your control groups going back to the 8 hours, where you can see a pretty significant difference between this control group and that control group in less than 8 hours. And then lastly, I gave this talk, and I can't remember what I did it for, but I was talking about the conversion rates of spinal cord injured patients, and I thought it was truly amazing. If you look at this, and Michael, you might not be able to see this, but what happens is it's always been around the 10% rate going way back. And then what happens is I was trying to figure out why in the last 20 years we do so much better. And so here's the conversion rates over time from the Asia A's, which is pretty impressive. Guidelines came in first, and that's when you start seeing the effect. And then two is Staskis came in here, which I think is a 1+2 effect where it comes out. But steroids really didn't do a lot in the overall picture. And so if you had to give me my things, early surgery, number one, number two is hyperperfusion, and number three is probably steroids as an option.
Agree with that, Michael?
I think that's probably a pretty good summary. And I think at the end of the day, this is kind of what I suggested at the outset of the talk. I think that, Jim and I are kind of presenting different sides of the argument, but I think, for the course participants, I think it's important to kind of walk away with the message that corticosteroids aren't the panacea, but it's a reasonable option to consider in your patients. And don't be afraid of the complication risk, because we're just not seeing that in these patients.
No question from Mayans, comments? Done. We thank both of you. Great, spectacular. Thank you, Michael.